أكيد يوتيوب يسوي فينا نفس الشيء. تمام.
Good evening, everyone, and welcome back to our second session. The second session will be about advances in hematology and oncology, pharmacotherapy, and our moderator for this session is Dr. Khalid Al-Huwaish. Dr. Khalid is the manager of the oncology pharmacy in King Fahd Specialized Hospital in Dammam. Please join me to welcome Dr. Khalid.
Assalamu alaikum. Thank you, Dr. Anwar. Thank you so much, the organizer. And this is my pleasure to be moderator for the second session today. And this is my meeting for today. We will have in this session we will have 3 speakers, and for the first speaker we will have Dr. Afnan Noor. Dr. Afnan is a board-certified oncology hematology clinical pharmacist from King Abdulaziz Medical City, Prince Noor Oncology Center. Dr. Afnan received her Doctor of Pharmacy degree from King Abdulaziz University, Jeddah, 2016. She's completed pharmacy postgraduate year PGY1 in 2019 at King Abdulaziz Medical City. Recently completed PGY2 in oncology hematology at King Abdulaziz Medical City, Jeddah. He currently area of interest is solid tumor and clinical research. Dr. Afnan speak today will be about the role of PIK3CA inhibitor in breast cancer. Please welcome with me, Dr. Afnan.
السلام عليكم. صوتي واضح؟ So thank you, Dr. Khalid, for introduction. And I would like to thank the organizing committee and the SOPA members for giving me this opportunity to present this topic today. And it's really important topic because it's a new treatment line for hormone receptor positive, HER2 negative, advanced breast cancer. And it's really important to discuss such topics because those patients actually developing resistance with time, and there's always need for new treatment line for them. I have no conflict of interest to disclose. Throughout this presentation, we're going to review the PI3K inhibitor mechanism of action, and we're going to analyze the current evidence of PI3K inhibitor in treatment of breast cancer, and discuss the management of Alpelisib toxicity, which is one of the PI3K inhibitor. And finally, we're going to highlight on the Alpelisib place of therapy in the NCCN guideline. So if you have a patient of hormone receptor positive, HER2 negative advanced breast cancer who progressed after CDK4/6 inhibitor, is there any hope for those patients? Is there any new treatment line? We will see. So as we are discussing the PI3K inhibitor, it's important to discuss the basics. So PI3K AKT/mTOR pathway, it's an important pathway which play a major role in tumor growth, proliferation, survival, and progression, in addition to the resistance to hormonal therapy. So here, first, the growth factor attacks the outer surface of the membrane, which lead to the cross-phosphorylation and activation of PI3K inhibitor, and further activate the AKT and mTOR, as end result, cancer growth and survival. It's important to mention that there is a gene called PIK3CA, which encodes the PI3K alpha isoform. And once the patient is having mutation in this gene, that will lead to hyperactivation of PI3K pathway. Why PIK3CA mutation is important? Because the majority of the patients actually having a HER2 hormone receptor positive, HER2 negative breast cancer subtypes present in 70% of the breast cancer patients, and the PIK3CA mutation present in 40% of the hormone receptor positive, HER2 negative breast cancer. And as I mentioned earlier, it's treated with tumor development, disease progression, and endocrine resistance. I just want you to know that we have 2 types. We have the pan-PI3K inhibitor, like Olaparib, which again block the whole isoform of PI3K inhibitor, and we have the isoform specific, like Alpelisib and Toxicity. And it has been reported before that targeting the isoform specific will minimize the toxicity compared to the PI3K inhibitor. So when I did the literature review, I found these agents which studied in the treatment of breast cancer, and I'm gonna go briefly over it. I'm gonna mainly focus on the Alpelisib. Sorry for that. Which is the only agent got the FDA approval in May 2019. So Alpelisib studied in BYLieve-2 and BYLieve-3, which both of them were randomized controlled trial, phase 3. And we have the Sandpiper trial, which studied the Alpelisib. Again, it's a phase 3 trial. Alpelisib, it's really early to discuss it because it's only studied in phase 1 trial. And finally, we have the SOLAR-1 and the BYLieve trial, which I'm going to discuss in details in the upcoming slides. So let's start with the BYLieve-2. It's a randomized controlled trial which compared Alpelisib plus fulvestrant compared to placebo plus fulvestrant in patients who progress after aromatase inhibitor. And if you can see in figure 1, you can see there's a clear separation in the curve showing superiority of Alpelisib plus fulvestrant in terms of progression-free survival and PIK3CA mutated tumors. And the result was consistent even in the BYLieve-3 trial, which almost studied the same arms, but they studied this combination in patients who progress after mTOR inhibitor. And again, the result is statistically significant favoring the Alpelisib arm. However, because of the poorly tolerated toxicity profile and it can cause liver toxicity and mood disorder and overall limited efficacy, the clinical development of these agents was arrested. So moving to the second one, the Alpelisib. Again, it's compared between the Alpelisib plus fulvestrant compared to placebo plus fulvestrant. And it showed the PFS in PIK3CA mutated mutant tumors like a modest efficacy with a p-value of 0.037. And again, because of the toxicity, the clinical utility of this combination there was no clinical utility for this combination because of the modest clinical efficacy and the safety concern. So the Alpelisib, we will start talking about the SOLAR trial, which is a randomized multicenter double-blind phase 3 trial, which studied the Alpelisib plus fulvestrant compared to placebo plus fulvestrant, and both in two cohorts, the PIK3CA mutant cohort and the second cohort, the non-mutant cohort as a second cohort. And patients who were hormone receptor positive, HER2-negative advanced breast cancer who progressed after a prior aromatase inhibitor. With the primary endpoint was progression-free survival, and second endpoint was overall survival. If we notice here in the baseline characteristic, we can see that majority of the patients having secondary endocrine resistance, and only minority of the patients having prior CDK4/6 inhibitor, around 6% of the patients. And it's been demonstrated that the PFS in the PIK3CA mutated tumors almost doubled in the Alpelisib arm compared to a placebo arm, with median progression-free survival of 11 compared to 5.7 in placebo arm, with hazard ratio of 0.65. And according to the recent overall survival result, which presented in the last ESMO virtual meeting in September 2020, the overall survival was prolonged by 7.9 months for patients in Alpelisib plus fulvestrant. However, it was numerically and not statistically significant with p-value of 0.15. And if we dig deep, we can notice that the patients with lung and liver metastasis, and the patients who are having secondary endocrine resistant, they are having statistically significant PFS favoring the Alpelisib arm. And here we can see the overall response doubled in the Alpelisib arm as well. And if we looked at the safety profile, we can notice that grade 3 adverse events were the hyperglycemia. The most common was hyperglycemia with around 30% of 30% of the patients had grade 3 hyperglycemia. And we have 6.7 grade 3 diarrhea. Rash occurred in 10% of the patients, and stomatitis occurred in 2.5% of the patients. So to conclude, the SOLAR trial showed a significant prolongation of PFS and greater overall response with Alpelisib arm among patients with PIK3CA mutated hormone receptor positive HER2-negative advanced breast cancer who had relapsed or progressed after endocrine therapy. It's treated with, it had numerically prolonged, not statistically significant overall survival, and with higher incidence of hyperglycemia, rash, and diarrhea. Now moving to the second trial, which mainly focusing on patients who received CDK4/6 inhibitor and assessing the efficacy and safety of Alpelisib plus endocrine therapy in patients with PIK3CA mutated hormone receptor positive HER2-negative advanced breast cancer. And this non-comparative multi-cohort phase 2 trial actually having 3 cohorts, and it's based on the prior treatment. So the first cohort, the patient who received CDK4/6 inhibitor plus aromatase. So those patients received Alpelisib plus fulvestrant, and the patient who received CDK plus CDK inhibitor plus fulvestrant, they received Alpelisib plus letrozole. And mainly, I'm going to discuss the cohort A analysis, which has been presented in the last ASCO meeting, May 2020. And with primary endpoint of proportion of patients who were alive without disease progression at 6 months. Here again, a SOLAR trial, the secondary endpoint, the secondary endocrine resistance was in 60% of the patient. And the primary endpoint was showing that 50% of the patients who were alive without disease progression at 6 months, and with 7.3 as median PFS. And here we can see that discontinuation rate in BYLieve trial was lower compared to SOLAR in terms of hyperglycemia. We have here 1.6, and here we have 6.3. And the median relative dose intensity for Alpelisib were higher, a little bit, 89 here, and here we have 83. So to conclude, the BYLieve demonstrated clinically meaningful efficacy for Alpelisib plus fulvestrant in PIK3CA mutated hormone receptor positive HER2-negative advanced breast cancer post-progression on CDK4/6 inhibitor plus aromatase with manageable side effects. So moving to the second part of our presentation, which is the management of PI3K inhibitor adverse events. It's mainly hyperglycemia, skin toxicity, and diarrhea. So let's start with the hyperglycemia. It's dose dependent, and it's typically developed within the early in the treatment course in the first 2 to 4 weeks. And the safety profile of Alpelisib in those in type 1 diabetes mellitus and uncontrolled type 2 diabetes mellitus were not established. They excluded those patients. So we shouldn't use it with those patients. Monitoring, we have to monitor the fast blood glucose during the cycle 1, day 8 and 15, then monthly, and you have to check the A1C quarterly. And also you have to know at what time you have to consult the diabetologist if you are having grade 1 or 2 or grade 3 not resolving within 5 days, or for sure if you have grade 3 or 4. So mainly, if you are having grade 1 or 2 hyperglycemia, you can add metformin, or you can either you can go up with the dose, and you may add pioglitazone as well. If if the patient did not resolve, if the hyperglycemia did not resolve to grade 1 or less within 3 weeks, we can consider dose reduction. If we're having grade 3, we have to omit the alpelisib, and we have to consider IV hydration, start again antidiabetic medication, or we may consider insulin for a couple of days. If the patient did not, if the hyperglycemia did not resolve within 5 days, we have to again reduce the dose by 1 dose level reduction. And if the patient did not resolve within 3 weeks, we have to permanently discontinue the medication. And for sure, if the patient is having grade 4, you should discontinue the alpelisib permanently. Skin toxicity, it's reversible for sure. And the onset, it's occurred within the first 2 months. It can affect any part of the skin. Usually, usually in type of micropapular rash, pruritus, and burning sensation or dryness, and it's worsened by skin exposure. And it has been shown in the BYLieve trial that using the prophylactic antihistamine decreased the incidence and severity of rash. So the management, mainly you can, in grade 1 or 2, you can consider antihistamine. It's better to consider antihistamine and local topical corticosteroids. If the patient did not resolve within, did not improve within 1 month, it's better to consider low-dose systemic corticosteroids. For grade 3, it's better to omit the alpelisib and to consider the same management in grade 1 or 2, and to consider a biopsy for central assessment, and to restart the alpelisib with, once the toxicity resolved, with reduced dose reduction if it's a second recurrence, and to continue oral corticosteroids and antihistamine if the patient still having symptoms, especially if it's grade 2 or more. For grade 4, it's better to discontinue it permanently and to consider IV antibiotics if there is risk of superinfection. So moving to the last part, which is the diarrhea. It's better for grade 1 and 2 to add loperamide, and if the diarrhea persists, to add opium tincture. If not resolved within 2 days, to treat it as a grade 3 or 4. For those patients, it's better to consider hospitalization and to, for sure, to stop the alpelisib and to initiate again the same antidiarrheal medication, IV hydration, etc. If the patient did not, if it did not resolve after 24 hours, it's better to add corticosteroid, octreotide, and to delay the next cycle by 1 to 2 weeks. So the last part of the presentation is the place of therapy of alpelisib. As you can see in the NCCN guideline, they're recommending the alpelisib and PIK3CA mutated tumor with fulvestrant as category 1 and in the second line setting for hormone receptor positive, HER2 negative advanced breast cancer. With that, I'm going to conclude with this slide. The PIK3CA mutation leads to hyperactivation of PIK3 pathway, which is associated with tumor development, disease progression, and endocrine resistance. Alpelisib is PI3K alpha selective, showed a significant prolongation of PFS with fulvestrant patient progressed after aromatase inhibitor or CDK4/6 plus aromatase inhibitor. Alpelisib is the only PI3K inhibitor approved for treatment of hormone receptor positive HER2 negative advanced breast cancer and preferred in the second line setting. The most common side effects of alpelisib is diarrhea, rash, and hyperglycemia, and it's need prophylaxis for example, antihistamine, and monitoring and treatment as well. The role of patient education with alpelisib is crucial as it's an oral medication and associated with many side effects. And thank you for your attention. If you have any question at the end of this session.
Thank you, Dr. Adnan. And I think the question and answer will be at the end of the session. Now we will have the second lecture. The second will be with Dr. Abdullah Zahrani. Dr. Abdullah graduated with a PharmD degree from King Abdulaziz University in 2016. He completed pharmacy postgraduate PGY1 in King Saud University Medical Complex and in 2018, and his PGY2 in hematology and oncology, currently in the final step. With the best of luck for him, inshallah. And currently, he's working as hematology and oncology clinical pharmacist at King Saud University Medical Complex. Dr. Abdullah will speak today about the role of PARP inhibitor in prostate cancer. Dr. Abdullah, welcome. Please welcome with me, Dr. Abdullah.
Hello, thank you, Dr. Khalid, for this introduction, and thank you, Sopsa, for this opportunity, and thank you all for coming here. So I will talk about the role of PARP inhibitors in prostate cancer. As we all know, PARP inhibitors have revolutionized the treatment of ovarian and breast cancer, and now we have new data to see the role of them in prostate cancer. I have nothing to disclose. So first of all, we will focus our attention on the subgroup of metastatic castrate-resistant prostate cancer. They are defined as a progression clinically, radiographically, or biochemically, despite castrate-level testosterone. So just a refresher, the current standard of care for prostate cancer is that you will start with hormonal agent, one of the new hormonal agent, or a taxane. Then as second line, after progression, you will switch either from taxane to hormonal or vice versa. So what is happening? Why these cancer cells metastasize? When they looked at it, some data that showed that up to 20 to 30% of the cancer cells, they acquire the BRCA mutation or other non-BRCA but related mutations, mainly ATM mutation. So this BRCA mutation, as you know from breast and ovarian cancer, is an essential part in the homologous recombination repair pathway for double-strand breaking. So with inactivation of these BRCA enzymes, what happens is that the cancer cell become genetically unstable because you don't have pathway to repair it, and this eventually will accumulate mutations, and with these mutations, the cancer cell will acquire new abilities to invade and so on. So how the cell will survive, it will be dependent wholly on the other pathway, which is the single-strand repair. So this diagram just shows the different pathways for the managing the damages for the DNA. So we have the single-strand and the double-strand repair pathway. So the single-strand is an inefficient way for repairing the double-strand breaks. And in the double-strand break, we have two other pathways, which is non-homologous end-joining and homologous recombination. So the non-homologous end-joining is just a random process. You just add base pairs to the cleaved side. So this pathway is associated with high mutation burden. However, the homologous recombination, the cell is trying to take another chromosome, another normal chromosome as a template, and it will synthesize the new double strand. So this pathway is very efficient. The mutation rate is low. So now you can understand that with inhibiting the homologous recombination, the cell will depend on other highly inefficient pathways. So the BRCA plays a very essential part in the homologous recombination. The BRCA is a complex. It will bring other proteins in the damaged side, and then you have a process called strand invasion, where the cleaved side of the DNA will slide into the new chromosome or the normal chromosome, and then the DNA polymerase will synthesize the new strands. So BRCA is a very essential part in this process. So now, with our understanding of the BRCA mutation in the ovarian and breast cancer, they come up with the synthetic lethality concept, which is by inhibiting the other pathways, by inhibiting the single strand repair pathway. So now the cancer cell doesn't have any way to repair the damages. So what happens is that the cell will go into a chromosome catastrophe and they eventually will die. What about the other normal cells? The normal cells, they still have the double strand intact. So by inhibiting the single strand, the normal cells can survive by applying the other pathway. So this will give you a selective toxicity to the cancer cells. This is a diagram just explaining how the PARP enzyme works. So the PARP enzyme is attached to a single strand, and it will repair the damage occurring in this strand. So by inhibiting PARP enzyme, eventually the single strand will become a double strand break. And of course, the cancer cell with a BRCA mutation cannot repair this double strand break. It will go into apoptosis. So this is the basic idea of synthetic lethality and using PARP inhibitors as a rationale. So what is the evidence of PARP inhibitors in prostate cancer? So in May 15, 2020, Olaparib have received FDA approval for metastatic castrate-resistant prostate cancer with BRCA mutation after using hormonal agent and a taxane. Following that, with just 4 days, Olaparib also received an approval, but then this time it is approved in BRCA and other 14 genes, non-BRCA genes, that is responsible for the same pathway. So we'll start with Olaparib. This is the PROfound trial. It's a landmark trial published in 2020. They compared Olaparib versus other new hormonal agents in the metastatic setting after progressing on hormonal agents. So they divided the cohort. Cohort A is BRCA and ATM mutation, and cohort B is the other non-BRCA mutations. This is the baseline characteristics. You can notice here that the BRCA2 is the bulk of the patients, and this is characteristic for the prostate cancer. Actually, most of the prostate cancer, they come with BRCA2 versus BRCA1, while if you remember in the ovarian and breast cancer, it's more balanced between BRCA1 and BRCA2. The other interesting thing about the prostate cancer is the prevalence of the ATM mutation. So you have a significant number of patients with ATM mutation. So you can see here the results. It's very clear that the Olaparib arm is superior to the new hormonal agent. And actually the lines have started to separate from 2 months. This reflects the magnitude of the effect of PARP inhibitors. So we have a hazard ratio of 0.34. And this is the results in the combined cohort A and B, also similar results. So the safety with the PARP inhibitors or Olaparib in this study is consistent with the safety data that we know. So anemia is the most common, nausea, vomiting, and diarrhea are all very common side effects with these agents. This is the subgroup. Interesting thing is in subgroup, if you see here, BRCA2 had the best response compared to the other mutations, ATM, CDK12, and CHEK2. And this will start a theme that will go on for a big part of the presentation, is what is the differential response of different genes to the PARP inhibitors? Can we give PARP inhibitor even to non-BRCA or not? The other thing is that you can see here a mutation called PPP2R2A. It had actually a worse outcome in the Olaparib arm. So the current recommendation is if this mutation present, it's not recommended to start PARP inhibitors. The PROFOUND group have published a new update for the survival data, overall survival. Again, PARP inhibitor or Olaparib have overall survival of 19 months versus 14 months, and this is despite a substantial crossover. So about 60% of the hormonal arm, they crossed over to the Olaparib arm. Next, we have a phase 2 study, Olaparib combined with abiraterone, which is one of the new hormonal agents. And this is based on the hypothesis that the two agents have a synergistic effect. However, one of the big limitations of this study is that the genetic status is highly unknown. So 70% it's not known what's their genetic status in regard of the homologous recombination repair. However, the results show that the combination arm have a superior effect versus the hormonal agent. The other study is the TOPARP-B Olaparib treatment. In this study's phase 2 trial, they looked at 2 doses. It was a dose selection study. Interesting results that I want to focus on this study is again the differential response with different genes. So you can see here the BRCA had the best response. However, when it comes to the ATM, it's slightly inferior results compared to the BRCA, and with the CDK12, it is the worst results. So the composite with the CDK12, you can see that the different component of the composite outcome is all 0. So CDK12 only responds in regard to the CTC conversion or circulating tumor cell conversion. Next, we have Rucaparib. This is the TRITON trial that received the Rucaparib the approval. It is a phase 2 ongoing trial. This study, they looked at the metastatic prostate cancer after progressing on a taxane and new hormonal agent. So the results, it mainly is a response, so overall response and PSA response was very good with Rucaparib. This is the subgroup. You can see again, BRCA1 this time versus BRCA2. So BRCA1 had a slightly less benefit versus BRCA2. So this is, again brings the question how we can treat or how we can select our patients based on the genetic subgroups. So the NCCN guideline have recommended screening all metastatic prostate cancer for BRCA and other non-BRCA mutation. And genetic counseling is highly recommended for germline investigation. So currently, Olaparib is category 1 based on the PROFOUND trial, and category 2B in patient who previously was on docetaxel. The PPP mutation is a contraindication to use Olaparib in this group. Rucaparib is approved only in the BRCA mutated after a taxane. ESMO had similar recommendations. So now we will focus on what is the role or the differential response of different non-BRCA mutation and response to the PARP inhibitor. We know that in the ovarian cancer, even in non-BRCA mutation, if the patient had an initial response to platinum, we can give PARP inhibitors. And this is because of the non-BRCA mutation. However, in the prostate cancer, it seems to be a little bit different. So this is an analysis published by the TRITON group who studied Rucaparib. They took all the non-BRCA mutated cases and they looked at them. So we ended up with 78 non-BRCA patients. About 50 patients had the ATM mutation, CDK12, 15 patients, CHEK2, about 12 patients, and they divided the other mutations like PARP2 and only 14 patients. And this is the results. This is the radiographic response for the ATM mutation. You can see here the only 10% have responded with the ATM mutation. And this is the PSA response. You can see that most of the patients with ATM, they had a biochemical progression or at the best, only stable disease. And this is the other mutation, CDH2. Again, most of the patients have only stable disease. CHEK2 also. However, when you look at the other genetic groups, they had a better response compared to the CHEK and CDH2. So we have a significant number who responded with the other mutation. And this is the radiographic response to the CHEK CDK12. Again, inferior responses. However, with the other mutations group, we have about 30% confirmed response. So when they took the other, so you can see that the other group, they had a better response than CHEK2 and CDK12. They identified that the PALP2 mutation had a very good response compared to the other. About 57% they had radiographic and PSA response. So the author concluded that there is a limited response to PARP inhibitor in those with ATM, CDK12, and CHEK2 mutation. However, PALP2 is still a promising finding for the response of PARP inhibitors. So what is the difference between this, all of these mutations? Why we have this differential response? So this diagram can summarize the whole process. So here we have the BRCA. They are directly associated with the DNA breaking. However, the ATM and CHEK2, you can notice here they are separate, somewhat separate. They are mainly responsible with regulating the whole process. So the ATM role mainly is to stop the cell cycle when double-strand break happens, to give the cell time to repair. So with this, some scientists and some researchers have hypothesized that maybe because the ATM and CHEK2 is not directly related to the BRCA, this might explain the inferior results with PARP inhibitor. However, you can see the PALP2 and the BRIP, which is in the other classification, they are directly associated with BRCA. So this might explain this differential response. So the whole idea from this is that some of the mutations that is not related to the BRCA, like ATM and CHEK2, they might have an inferior response. However, some of the mutations that we know they are directly associated with BRCA, you might expect the same or similar response to the BRCA mutation. This is some pharmaceutical tips for the two agents that we have, Olaparib and Rucaparib. So Olaparib, the approved dose is 300 milligram BID. We have some dose adjustment to the toxicity. Of course, Olaparib is renally adjustable. However, Rucaparib, there is no recommendation to adjust for the creatinine clearance. Olaparib is SAD3A substrate. Rucaparib is mainly SAD2D6. MDS and AML, this is a class effect, so it's important to monitor the patient hematologically. Olaparib, some deaths have occurred because of pneumonitis. It's very rare, however, it's fatal if it occurred. So if the patient have pneumonitis due to Olaparib, so this is a recommendation to stop the agent. Of course, anemia, this is a class effect, and it's an on-target effect because the erythrocyte, they depend on the PALP2 enzyme for the growth. So this is just to remind ourselves about the medication, how they work. So all of them, they have a common structure which is related to the NAD. So the NAD is attached to the ADP, and the PARP, of course, it's a ADP ribose polymerase. So it's a kind of fooling the enzyme for NAD. So what about ongoing trial? We have a lot of ongoing trial, phase 2 and phase 3 trials. Many of them are trying to answer the debatable issue about the different genes and different responses. One interesting trial is the TRAP trial. They are studying a novel medication, which is an ATM inhibitor, if you remember the diagram. So now they are combining PARP and ATM inhibitors in this study. And another one is the COBRA trial. They are trying to assess the Olaparib response after using a platinum, just like in ovarian cancer. There's other studies in the other PARP inhibitors, Alpelisib and Niraparib, are also ongoing. So just to summarize all of this, all metastatic prostate cancer should undergo genetic analysis for BRCA and other non-BRCA mutations. Olaparib is recommended after progressing on hormonal agents. However, keep in mind the specific mutation, the PIK3CA. This is associated with inferior or worse outcomes with Olaparib. Rucaparib is recommended only in the BRCA mutated and after using a taxane. There is currently uncertainty what is the response of patients with ATM and CHEK2 mutations. So from the limited data that we have, you might expect at most a stable disease with these mutations. So with this, I conclude my presentation. Thank you.
Thank you, Dr. Abdullah. Again, please, question and answer will be in the end of the session. For the next speaker, we will have Dr. Abdullah Rajhi. Dr. Abdullah obtained his Doctor of Pharmacy from Massachusetts University, Boston, United States in 2017. Then he recently completed BGY2 in Hematology Oncology at King Faisal Specialist Hospital and Research Center, Riyadh. And everybody know, mashallah, he on the third place. Well done, Abdullah. Dr. Abdullah will speak today about the role of anti-CD79B in refractory diffuse large B-cell lymphoma. Please welcome with me, Dr. Abdullah. Dr. Abdullah.
So good afternoon, everyone. Thank you for the organizing committee, and thank you everyone for the attendance. So hopefully, inshallah, this will be a very fast presentation. We know that we are exhausted already. So hopefully, inshallah, you will get to, we'll get to inshallah finish as soon as possible. So my today talk will be about the role of anti-CD79B and relapsed refractory diffuse large B-cell lymphoma. I have nothing to disclose, and then I'll talk just a little bit about the diffuse large B-cell lymphoma and the treatment options, and then the role of the anti-CD79B in the relapsed refractory diffuse large B-cell lymphoma. So we know 10 years ago that the standard of care for diffuse large B-cell lymphoma is CHOP. And then after the addition of rituximab, which increased the progression-free survival and overall survival based on the Guideli trial, that was the standard of care from that time until today. So the thing is that for these patients, usually they are cured from the disease, about 70% of them. Now, the problem is that we have about 30 to 40% of these patients, they actually became relapsed or refractory to treatment. Now, for these patients, usually we put them for salvage therapy plus the autologous transplant. That's also a problem because about 50% will achieve cure for that, but we have also 50% that will not achieve, and they will have to go for a second-line treatment. So the thing for those patients with autologous transplant, prior to the autologous transplant, their disease, if they were in complete remission or partial remission, that also will impact the survival rate. So very important to achieve complete remission prior to the autologous transplant. The other issue, below or prior to the CAR-T and CD79B era, we know that diffuse large B-cell lymphoma, who relapse after autologous transplant, usually have only 1 or less than a year of survival, especially if the relapse happened after the autologous transplant within like the first 6 months. After 6 months, the survival is actually increased for more than a year, and the longer the relapse, the relapse or the time from the autologous transplant to the relapse, the longer the survival for these patients. And so, if you looked into the right Kaplan-Meier, you see that patient who's more, or for example, 6 to 12 months, they have actually better overall survival than compared to this patient who is between 3 to 6 months or less than 3 months. So another issue is that if those patients were not or transplant ineligible. Now, if those patients are transplant eligible, we only give them chemotherapy, and they have a very poor prognosis. So they only live around, they have a median overall survival about 4 to 6 months. So that's another issue for these patients. And usually they don't have any other option other than chemotherapy. Again, that's prior to the CAR-T and prior to the anti-CD79B. So, you remember about some of the data, for CAR-T, for example. We know that this glucosel, when was given for patients who relapsed for about 2 second-line therapy, the patient have a very good complete response, something that we didn't achieve with other chemotherapy, which is about overall response rate of 52%. That's after they receive 2 lines of treatment. That's not something that we saw before with chemotherapy only. So, and they have about 40% of these patients had a complete response. Again, these numbers never seen before. That's actually interesting. And those patients who actually achieved complete response were able to sustain their response for about 2 years or even more. So that's very interesting about CAR-T and very good results. Axicabtagene ciloleucel also was able to produce a very interesting overall response rate, about 82%. And also the complete response was about 50%. And those patients, a lot of them sustained the complete response up to 2 years or even more. So that's interesting, and that's very exciting about CAR-T. The only issue is that we don't have CAR-T right now. So that's the whole issue. And for these patients, and we know that maybe one center right now, they are going to start their first CAR-T, but we don't know when we're going the other centers to have it. So that's one issue for these patients. And sadly, hopefully, inshallah, we'll have it soon. But that's something that we have to deal with that right now. So we have to have we have actually 3 issues. One, that we don't have an access to CAR-T for these patients. The other thing is that those patients considered ineligible for transplant. What should we do for these patients? And the third thing is patients who do not achieve complete response. We know that, as I said in the slide before, any patient who did not achieve complete response, their survival decreases prior to the autologous transplant. After transplant. So for that reason, we're going to talk quickly about the apolituzumab vedotin. And we know apolituzumab vedotin is an anti-CD79B, which is expressed in 95% of the B cell. So usually you don't have to do to look for the CD79B. And the concentration of the CD79B is not important. So the apolituzumab vedotin is that it's similar to brentuximab, specifically similar to it from the way that it's actually internalized and then become degraded and then release the MMAE, and that will bind to the microtubules. That will also inhibit, that lead to the G2 and M phase aggression tumor cell apoptosis. Now, because it's affecting the microtubules, we know immediately that those patients will suffer peripheral neuropathy, like taxanes and brentuximab and also vincristine. So what's the rule if in relapse refractory? So we know in the phase 2 trial which was done in diffuse large B-cell lymphoma, the escalated dose that they reach is about 2.4 milligram per kg, with majority of patients receiving at least 3 lines of therapy. If you looked into the complete response here, down in the diffuse large B-cell lymphoma, you'll see 4 patients had complete response and 10 patients had partial response. So that's a good thing that again, we don't see it with chemotherapy. And that's based on that, it was established the dose of apolituzumab to be 2.4 milligram per kg. But the other issue also we have to understand that is the grade 3 and 4 side effects and the safety for these patients. A lot of these patients experience neutropenia, about 40% of them, and anemia, and also peripheral neuropathy with that dose of 2.4. So imagine if you combine it with a medication that causes bone marrow suppression. So for these patients, you have to think about to adjust doses rather than giving the recommended doses, the 2.4. So that's what they did in the phase 2 trial, which is the Bolitizumab vedotin in relapsed and refractory diffuse large B-cell lymphoma. And that trial actually got the FDA approved for Bolitizumab. So this is actually a phase 2 trial compared Bolitizumab vedotin in combination with bendamustine and rituximab. And they compared it to only bendamustine and rituximab. And they, because if you looked into the data for, and I put brontuximab, it should not be brontuximab, it should be bendamustine. But if you looked into the overall survival, it's only produced about 6.3 months for the only combination, the PR, the bendamustine and rituximab. And so they added bolituzumab, and they tried in a patient who at least failed one line of therapy, that's including transplant. But when patients who are ineligible for transplant or failed transplant were also included. And their primary endpoint was to see the complete response at the end of the treatment. So they give bendamustine, 90 milligram, and day 2 and 3, and then they give also rituximab or obinutuzumab. Obinutuzumab, we know the last Goya trial showed no statistical difference between the rituximab and obinutuzumab. So that's this trial was recruiting before that. So because of that, they actually included in the trial. And also patients who had patients received bolituzumab vedotin, but they give only 1.8 because again the bone marrow suppression that they expected with this combination. So they decreased the dose from 2.4 to 1.8. And that they tested that dose for the phase 1 trial. When what they did is that for bolituzumab, because of the infusion reaction, they give antipyretic and antihistamine 30 minutes prior to it. They give also PGP prophylaxis. They also give herpes prophylaxis throughout the treatment. And they, for bolituzumab, they did not do any renal adjustments. And patients with a total bilirubin of 1.5, above 1.5, or ALT/AST above 2.5, they actually hold the dose or delay it. So the baseline characteristic for most of these patients were mostly were male. The ACOG was about 0 to 1 mostly. Most patients also had an RR stage between 3 to 4, and most had an IP score between 3 to 5. And half of these patients have an activated B cell and pathology. And only of these patients, about 25% of these patients had bone marrow transplant. So most of them were ineligible because of their age and comorbid conditions. I just put it there for the efficacy. If you looked into the patients who received PR, for example, the complete response was only 17.5% compared to 40% of patients who received the combination. And that also applies for the partial response. More was with the combination therapy. So when it comes to progression-free survival and overall survival, also we saw a benefit in progression-free survival OS in those patients who received bolituzumab, bendamustine, and rituximab, with a progression-free survival of 9.5 months versus only 3.7 months with a hazard ratio of 0.36. The overall survival was also seen benefit in the combination. I didn't put the subgroup analysis, but the benefits were seen in respect to all patients and respect to the patient criteria and staging. And the thing is, the dual expressor, those have a MYC and BCL2, they also show benefits from the combination. Now, the problem is that the patient who would have a double hit or triple hit, those patients, they were included, but there's no patient where in the end. So one of the inclusion criteria was to have those patients, the double or triple hit. However, there's no patient by pathology where considered to have a double or triple hit. So when it comes to safety, of course, you will see more side effects with the combination, more than the bendamustine and rituximab. But the thing is that treatment completion rate was actually higher with the combination because of the disease progression with the bendamustine and rituximab. So that's actually give us a good indication about the two combination. Adverse effect was the most common with the discontinuation of the combination. About 33% of these patients actually discontinued the therapy. And last thing is the dose reduction paltusotine was only due to peripheral neuropathy and happened in 2 patients. What about if the patient have bone marrow suppression that lasts more than 7 days? In those patients, we usually adjust the bendamustine. But if it happened in the second time, then you have to adjust the paltusotine. So the bendamustine, first you adjust it, and then you adjust the paltusotine in the second one. And this is tells you about the side effect. Of course, neutropenia and anemia was more, and thrombocytopenia even was more with the combination. And if you look into the peripheral neuropathy, interestingly, no grade 3 or 4 for the people who received the paltusotine, bendamustine, and rituximab, but mostly was all grade 1 or 2. So this is the last slide. So to conclude, we know that the paltusotine, bendamustine, and rituximab seem to be very effective therapy for these patients who is ineligible for transplant or even failed transplant who currently don't have CAR-T as of the situation right now. Also, the good thing about the combination, it induces complete remission. So it can help to be a bridge to have to transplant or even have the CAR-T, because we know with the CAR-T, if you put the patient in complete response, they will have a good response for a long time. So possibly, theoretically, if you put them in a partial response, and then you give them CAR-T and you put them in complete response, those patients will respond better with possible CAR-T. But this is just theoretically. As I said in the slide, in the peripheral neuropathy and neutropenia was very common with the combination. So possibly dose reduction and dosing delays or giving GCSF. But GCSF was given if the patient developed neutropenia, not with the protocol itself. So it should not be included at the beginning. And last thing is that, which I mentioned before, is that if you patient have bone marrow suppression more than 7 days, adjust bendamustine first, and then if the patient have a second occurrence, then you can adjust the whole paltusotine. And this is, I conclude my presentation. Thank you so much for listening. I appreciate you being attended. Thank you.
Thank you, Dr. Abdullah. And I think all my speakers, they are journalists, all of them below the time, less than 20 minutes. Okay, now we see there is any question, I think in our webinar, they don't have any question. We'll see from the audience, if there is any have a question, please, from the audience. Dr. Aisha.
السلام عليكم ورحمة الله.
عليكم السلام.
So thank you very much for all the speakers for today. It was a very rich presentation, and this may be a comment rather than like a question. So now we know that we have a lot of medication that came to the market, and you know that all as clinical pharmacists we sometimes we stop in halfway. We don't know should we go and approve this kind of medication or not, especially that we don't have a local data compared to the international. So our knowledge usually based in the international data. So do you have, from SOPA point of view, and all the clinical pharmacists attending for today's lectures, do we have or do you plan to have a collaborative data or data registry for the patient in Kingdom Saudi Arabia, so to know that what kind of mutation that we have, so we can tackle that kind of mutation, and we can go for particular drug that we have to have it at the Kingdom level. This is the first question. The second one, if we, for example, have a precision medicine that we know that now this is the big deal in the oncology practice. So what you will do as a SOPA representative for all the big manager that attended the lecture for today. Thank you very much.
Thank you. Any comment? Okay, Dr. Majid.
Thanks, Dr. Aisha, for bringing this point. 2 points actually I've mentioned. I'll start with the second one, which is the biomarkers. Unfortunately, we have major issues with this issue. I mean, the testing, not only in our hospital, but in the level of our country. So now I think there is like a plan, like on the health level, to have a kind of central lab to do this testing. We know that most of the new medications are biomarkers driven, so we need to have these tests available to help in the treatment, the best treatment selection. So as a SOPA, I don't think that we will have like we cannot like force them to make these biomarkers available, but we need to emphasize on the importance of having these tests available, at least in one central lab, certainly for the hospitals. And I think we are working on something like this. Dr. Abdullah here, he did a kind of survey, maybe he will share it with us later. And with regard to the first point, was about the medication access or the experiences. Unfortunately, these medications are very new medications. Today we discussed Olaparib and PARP inhibitors, Olaparib, as well as the Apelisib in the first lecture. These medications are recently approved by Saudi FDA. So if you ask the hospitals about the number of cases that they used, for example, National Guard, we have only 4 patients for prescribed pertuzumab as a compassionate use. We never received it as either formulary or non-formulary. So we have very limited experience with pertuzumab. For PARP inhibitor, I can recall 1 patient. My patient started on Olaparib after failure of all lines in prostate cancer. And I think he was lucky to receive this medication because he was BRCA positive. And again, he just started like a couple of months ago. I cannot assess that the safety and efficacy. And with regard to Alpelisib, it's recently approved by Saudi FDA, and we have seen patients. To conclude my second part, it's very important to develop our own experience by conducting real-world studies. And this is what exactly we did with the in different institutions experience with immune checkpoint inhibitors. Now we have better local data with regard to safety and efficacy. But I think it's really important to have this real world studies.
Thank you so much. Dr. Ashraf,
Dr. Zahrani, thank you for the interesting research. The Olaparib cost per month, how much?
I'm not sure actually about what the cost per month about the Olaparib. But if you are meaning to compare it with other, and if you have a patient with BRCA mutation, this is your first line after progressing.
We don't have any other, I mean, could be, for example, cheaper alternative.
Cheaper alternative as a targeted agent in BRCA mutated patients. There is new data for those who progressed on docetaxel by using cabazitaxel, the second generation. However, the issue of that study is that the genetic data for the patients who included is not known. So we are here in cabazitaxel versus PARP inhibitors. We don't have a direct comparison. However, the patient, I have a patient who have a BRCA mutation, so the cost here is not really an issue because I don't have another strong alternative to them. Even cabazitaxel is expensive.
Thank you.
Thank you. Any other question? For me, I have one question or two really. For Dr. Abdullah, what about the combination with pembrolizumab? Did you start with your patient as a combination therapy for prostate cancer?
You mean the abiraterone and the
Yeah, all of it.
so this study, again, the issue is that 70% of the patients we don't know the genetic status. Now we have a problem with the biomarker availability and its availability. So I think it's a bold movement. However, if you have a patient who progressed and I cannot do the genetic test, maybe I can rely on this study to give the combination blindly. But at least we have data that show the combination have a superior result. However, if I have a targeted mutation, I think I would go with just the Olaparib. No need for the combination because I have a target.
Okay, thank you. Second, for Dr. Afnan, we know it is contraindication with diabetic patient, but our community, most of the patients also they are diabetic. So if there is any new study, new guideline to start with them with a specific dose reduction, with the monitoring, with metformin starting to or give higher dose of metformin addition from the beginning. Do you have anything like this situation?
Thank you for your question first. Actually, there is no data that assists the uncontrolled diabetic, type 2 diabetic, and type 1 were excluded from the trial. But it depends on the clinical practitioner. It's clinical mainly. As there's no published trial.
If we start a patient like this situation, do you think we need to make more monitoring for them to make any more visit for the clinic to control diabetes?
Yeah, sure. If we start to control the patients before getting this medication, it would fit the criteria. There will be, if it's type 2 diabetes and control, they can receive it with monitoring and
What about the pre-diabetic patient? The pre-diabetic, but the meaning is when they do the fasting, they are around 110, 120. They are not more than 120 milligram per deciliter for the glucose level.
They can receive medication with monitoring for sure, assessment further.
Thank you. Any more questions before the closure? Okay. Thank you for the listening, and thank you for all the speakers. Dr. Anura, please.
Thank you so much, Dr. Khalid, and all our speakers today. We would like now to thank all of the participants in our second session. And we're going to start with Dr. Khalid Al-Hawaish. Dr. Afnan Noor. Dr. Abdullah Zahrani. And Dr. Abdullah Rajhi. By that, we would like to conclude our satellite and insight symposium today. We're very happy to have you, and inshallah more to come with Sopsa.
Before we conclude, I would like to appreciate our organizers.
Yes, and special thanks to the organizers.
Thanks to the pilot for this support. So we'll start. Alpelisib.
Dr. Apelisib.
سارة الفكري.
دكتور سارة الفكري.
لازم تركز زميلات.
Thank you.
يعطيك العافية مصطفى، شكرا.